All right, welcome everybody to another session of Clinical Problem Solvers. I'm super excited today. Today we have a rheumatology VMR. I have a very special guest, Dr. David Leverins. He's the current rheumatology program director at Duke. He was my program director, and I'm so excited to have him discuss a case today. And afterwards, we'll all be able to. Blech, I'm getting nervous. We'll all be able to learn from him. And I'm just so excited because he's such an amazing teacher, and you'll get to see exactly why I came to do fellowship and trained at Duke. So I'm just super excited for this. For those of you who don't know me, um, I am one of the attendings in rheumatology at Duke with a specific interest in sarcoid and interesting cases. I attend and host the Duke Rheumatology Case Conference and really excited to share a case with you guys today. We have Mana Sweeney, who's actually going to present the case. And then Hans will be doing teaching points, and Mohammed will be doing scribing. So first, I'll let Dr. Leverins, if you want to share just like kind of a little bit of introduction about yourself, and then we usually do like an icebreaker question, like what got you into rheumatology. So if you have anything like that, please share with us.
Sure. Yeah. Thanks for doing this. Thanks for the invitation. I'm delighted to do it. I feel like I actually have big shoes to fill from what you do in our program, Jeffrey. So if y'all don't know, as Jeffrey mentioned, he runs our case conference and started doing that actually at the end of his fellowship. And we often look to him for tough cases. So now I have to put my money where my mouth is. I gotta back this up. So yeah, yep, I'm the program director at Duke. I trained at Vandy for internal medicine residency and then came to Duke for fellowship. Um, the reason I got into rheumatology is because my wife told me to do it. Uh, I was in medical school. We were married for 1 year, and I had a crisis where I didn't know what I wanted to do. Suddenly, the specialty I thought I wanted to do turns out wasn't me. And I then told her I wanted to do every medical specialty. And she was like, "Well, we're not doing this." So she read lists of medical specialties and said, "Why don't you be a rheumatologist? It sounds like you." And I said, no one does rheumatology. I'm not doing that. But then I did some rotations and actually turned out that I loved it. Complex problem solving tied with just long-term relationships with patients and getting to know them and getting to walk with them along their journey of rheumatic disease is a true privilege. So, and now I get to work with learners and fellows. So it's the dream job. Yeah.
I really love the story. Thanks so much for sharing it again. I'm gonna go to Manaswiti next to share how, introduce yourself and share how you're doing, and then we'll go over to Hans and Mohammed.
Hello, everyone. It was amazing listening to Dr. Leverins. It's great to have you here, and I'm really excited to present today. This is a case Dr. Jeffrey was kind enough to share, and look forward to presenting it, and looking forward to the discussion as well. Thank you.
All right, Hans, to you. How are you doing?
I'm fine, and greetings from snowy Huntsville in Canada. I'm excited to learn from the case. And yes, let's go ahead.
Awesome. Thanks so much for doing teaching points. And then I'll hand it over to Mohammed and Simi, who are scribing today to introduce themselves, and then we'll start the case.
Hello, everyone. I'm excited for today's case. By the way, I'm Mohammed Zubaidi, a medical graduate from Baghdad, Iraq.
Hello everyone, very excited for the VMR today and excited to scribe today.
Awesome. Manaswini, whenever you're ready, let's begin.
Yes. So here goes the first aliquot. A 37-year-old Asian woman presents with loss of consciousness in the setting of recent heavy menses. I'd like to continue. And it was 5 days ago, she developed sudden onset pleuritic chest pain, 7 on 10 in severity, and shortness of breath, especially while walking or sleeping. Pain and breathing was worst when lying down, especially at night, and the patient had to sleep with 3 pillows to have any sense of comfort. The patient and the husband thought she caught a virus, and she was given azithromycin by urgent care for possible pneumonia, but she did not have resolution of symptoms, and the patient has never had any chest pain before. One day ago, heavy menses started, 3 times more bleeding than usual, and the patient noticed small red spots under the skin scattered in her legs. And the PCP was concerned she may need transfusion, so the PCP directed her to the ER. That will be my first aliquot.
Okay, thanks so much for sharing this exciting beginning of the case, David. I'm just curious, this is like the very beginning of a case, and I'm just curious, do you have any thoughts of so far how you think through this, and anything come to mind from for the next questions that you would want to know from a rheumatologist standpoint?
Yeah, thanks. I mean, I think I'll put on general medicine hat first, before we go into rheumatology here. I mean, obviously, I think we always start with what brought them in, and that was the loss of consciousness. We have some description of some heavy menses, which of course immediately brings to mind some kind of volume issue. But there's, of course, numerous causes of loss of consciousness. So going through, I mean, my my training taught me that the first thing you do when you think about someone with syncope, besides check their blood sugar and do all the emergent stuff, is you find someone who was there or talk to the patient and ask them to take me minute by minute, second by second through what happened leading up to the syncope so that you can get some of those clues that might get you a cardiogenic or vasovagal or other etiology of that syncope, because we don't want to anchor too much on the heavy menses, and the as a volume issue. So I think that's step one, but it also seems like the timeline really started with this shortness of breath and pleurisy. So it's hard not to have my rheumatology hat on when I think about pleurisy or pleuritic chest pain. I mean, really, what you described actually sounds more pericardial, with pain that was worse when lying flat, with deep breathing. I mean, you would want to confirm that as she sits up and leans forward, that pain improves if we're thinking about pericardial pain. But that, along with dyspnea, and essentially orthopnea, seems to be suggesting some kind of cardiogenic problem. So recognizing that there are numerous reasons why someone can lose consciousness and have pleurisy and pericardial pain, what I'm most worried about in this patient is that something cardiogenic is going on with pericarditis, maybe cardiomyopathy, and then that somehow contributing to this loss of consciousness. If you tie in the heavy bleeding and the red spots, you also wonder about some kind of bleeding diathesis, thrombocytopenia, or some kind of coagulopathy. So that's kind of where I am. I mean, I think we'd ask more cardiac, questions. I'd again want the second by second history of the loss of consciousness, et cetera.
Amazing. Such insight from just a little bit of history. And I like to think one of the reasons that brings us to rheumatology is that first we do internal medicine and we really enjoy internal medicine. I also like to think that to be a good rheumatologist, you also have to first be a good internist. And so Dr. Lover just really showcased just how much internal medicine knowledge that he still remembers and brings every day to him whenever he sees patients. So I love being able to understand how you think through this. Manaswini, would you like to share the next aliquot?
Yes, it's really humbling to be presenting this case to you. So here goes the next. So she did not trip This is about the loss of consciousness, but she was walking with her husband at the supermarket when she suddenly collapsed and was caught by her husband during the fall. There was no preceding symptoms, and she had felt very lightheaded the whole day. That started earlier that morning when she woke up. She fortunately did not suffer any injuries after the fall. When she woke up, she did not have she was not confused, but reported that she felt weak overall. Coming to the review of systems, the temperature was normal at home, there was no night sweats, and she experienced 10 pounds of weight loss in the past 3 months. Her arthralgia has increased from before during acute illness, but she was recently diagnosed with hypothyroidism, and her arthralgia affected multiple joints, including fingers, wrist, feet, knees, ankles, and it was symmetrical. 1 hour of morning stiffness, and she also had swelling in the wrists and hands occasionally. She had swelling in the bilateral feet and ankles, which was progressive over several days. She had pain in the muscles during acute illness with generalized weakness but no focal issues. She had thinning of hair in the past 6 months, and she describes fingertips to become pale in the cold. And she had sinus symptoms starting 5 days ago with viral like illnesses, including nasal congestion, cough, and sore throat and the rash as described in the previous aliquot, but there was no it was not photosensitive, or there was no facial rash as well. She had no dysphagia, no GERD, but she had non-bloody diarrhea for 2 to 3 days, uh, starting 3 days ago. That would be my second aliquot. We'll love your thoughts.
Awesome. David, I when I talk about clinical problem solving sometimes in this space, we talk a lot about how to differentiate signal from noise. And I like to think that one of our jobs as a rheumatologist is sometimes when patients come, they have a lot of different complaints and it can be overwhelming. So would really love to hear what your insights are with this information, given there's a lot of information here. And also if you have any strategies to share about how to not be overwhelmed or figure out what to focus on.
Yeah, thanks. I mean, this is a lot, but this is actually, the way that most of our patients come to us with these kinds of issues. A common phrase I have when I'm speaking with patients or with trainees is that um, we like to connect dots in rheumatology, but sometimes patients just have a lot of dots. And so this patient sounds like she has literal dots, which we'll maybe hopefully get to, but I mean, it's partly about pattern recognition and then also switching to some slower thinking to make sure that you're thinking comprehensively about this and not anchoring on the patterns. Because if I were to go by pattern recognition, well, here we have a patient with what sounds like symptoms of inflammatory arthritis, myalgia, and a recent episode of pleuritic pericardial chest pain, some red spots. I mean, the anchoring thing that is going to go on in my head is that this patient has lupus. I mean, that's just the first thing that's going to pop into my head as I'm thinking about this. And of course, there's a wide differential in that context. Is it actually lupus or MCTD or some kind of overlap syndrome or UCTD, or do they have rheumatoid arthritis with pericardial chest pain as well, which can happen, or the many other things that you think about that can basically blur the lines between these diseases. But I mean, how could my, quick thinking not do that? And so I'm obviously going to be asking the complete review of systems. And as I'm examining the patient, I'm going to be thinking about that. But you can also take a step back and look at some of these symptoms in isolation and make sure you have lists for them. So you've described weight loss. Well, that's concerning. I mean, hypothyroidism can be associated with weight loss, but typically it's the opposite. I'll also mention that the hypothyroidism that you mentioned complicates serologic testing a little bit, because many patients with hypothyroidism have Hashimoto's, which leads in many cases to a positive ANA. And it's actually very difficult without additional serologies to determine if that patient truly has lupus, if it's just a positive ANA in the context of Hashimoto's. So there's that. The pain that you described in the joints, again, there's probably two different things going on. You described swelling in the hands, symmetrical polyarthralgia, with 1 hour of morning stiffness. So and then you also described swelling in the feet and the ankles in the context of someone with orthopnea. So again, my suspicion, examination is required for this, is that there's primarily pedal edema, and then that's separate from the inflammatory arthritis that we're likely going to find. And of course, not all that is joint pain actually is inflammatory arthritis. So the hour of morning stiffness suggests inflammatory arthritis, but the general approach to joint pain is, first of all, you need to make sure it's intra-articular and not periarticular. And then you need to make sure it's truly inflammatory and not a non-inflammatory cause. And that then gets you to our nice box, if you've ever seen the 2x2 box, where it's like inflammatory arthritis, how many joints, and what's the chronicity. That can help you understand or kind of give you a paradigm of causes of the pain. And I will say that in that context, if we were to categorize this patient as inflammatory arthritis, I'm not sure I caught, you might have said it, how long this has been going on from an arthralgia perspective, but it does concern me a little bit as a rheumatologist that this seems to be more of an acute polyarticular inflammatory arthritis. Usually my diseases, like rheumatoid arthritis or lupus, are more chronic polyarticular inflammatory arthritides. So if this is a relatively acute process, that's a sign that we need to keep some mimickers in mind, like a viral etiology or something like that, like parvo or hepatitis or HIV or just a random virus that causes arthralgia in many cases. You need to be thinking about reactive arthritis or disseminated gonococcal infection, which I've seen before in a patient with lupus. So, and then, the sinus symptoms and red spots, that makes you think about vasculitis, like ANCA-vasculitis or granulomatosis polyangiitis, like maybe this patient has vasculitis. So there's a lot there, but I think in general, that's what I would say. Like if you were inside my brain, I would say, well, yeah, I'm going to anchor, or I'm going to come up with some kind of fast twitch. This is most likely this, and I'm going to really focus on that. But you also have to kind of take a step back and see what some of the things that point away from that are. I'll also mention, you mentioned the fingertips with pain in the cold. You got to really tease that out. Like, is that really Raynaud's? Is it just acrocyanosis? Is it actually red spots? Is it pernio, etc. So.
Awesome. Thanks so much for sharing all your insight with just this the history, and we haven't even gotten to like the past history or exam yet. So, which I'm really curious about is something that I don't have to do that often, but as an intern, so you have to make a decision. Is essentially you're saying there's a high likelihood of something maybe rheumatologic going on. Do you think at this point you would recommend this patient getting an ANA, and what kind of at what point do you think in this history would you say is the point that you would start to think this patient may need an ANA?
Yeah, I mean, you had me at arthralgia, inflammatory arthritis, pericardial chest pain, et cetera. I mean, I think that wins you enough stuff. But I mean, really, I got to examine her and really go through the exam before I'm going to recommend serologic testing. Yeah, but you'll hear from rheumatologists conflicting things about serologic testing. Will tell you never send an ANA, or don't do it then. And then sometimes then in cases when we're presented with it, we're like, yeah, I want an ANA for possible lupus. So these cases are hard. But yeah, when you're faced with a case where some of those dots could come together into a lupus-like syndrome, then certainly it's appropriate to send that testing.
All right, amazing. Thanks for sharing your thoughts. Manaswini, would you like to share the next aliquot?
Yes. So here goes the next. The patient had polyarthralgia for 6 months, and her past medical history includes hypothyroidism diagnosed 3 months ago. It was Hashimoto's, and she had an anti-TPO, which was positive. and she was started on levothyroxine, which is her only medication. She has carpal tunnel syndrome for the past 6 months and no past surgical history. There's no history of autoimmune disease or cancer. Social history, she's originally from China and just moved to the US 1 year ago. Her last trip back to China was 4 months ago. She has no pets at home and she works as a postgraduate researcher in a lab and works with lab mice. Physical exam, the vitals, temperature is 97. She's afebrile. Blood pressure of 85 over 65. Heart rate of 114. And saturating at 94% on 4 liters of nasal cannula. Her respiratory rate is 32. On general exam, she appears critically ill, waxing and waning mentation, but oriented times 4. HEENT exam, she has no oral ulcers. She has bilateral cervical, submandibular, and axillary lymphadenopathy. On cardiovascular exam, she's tachycardic, weak peripheral pulses diffusely, and jugular venous distension to the ear. Pulmonary exam, diffuse crackles and rhonchi heard bilaterally. Abdomen is soft and non-tender. Dermatological exam, multiple scattered, flat, non-blanching red spots under the skin of bilateral lower extremities, with few of them coalescing into non-palpable bruise-like lesions. Extremities, 2+ pitting edema to bilateral knees. And on musculoskeletal exam, there's diffuse swelling of the dorsum of the hand bilaterally. Would love your thoughts.
Oh, goodness. She's sick. Sorry, Jeffrey, were you going to say something?
No, I was just going to ask what your thoughts are. I was going to ask what your thoughts on the history were first and then moving to the exam.
Yeah. So, I mean, I think, it's a little reassuring to me from a rheumatologic perspective that arthralgia has been present for longer than more this acute scenario. Again, the chronicity is actually extremely important in many of these conditions. It isn't to say that someone cannot develop acute lupus. Vasculitis in particular can present quite quickly. It doesn't have to be a chronic process for it to be a rheumatologic issue. But specifically, when we're thinking about the inflammatory arthritis aspect of things, that chronicity is important. Keeping in mind, of course, that the patient also was diagnosed with hypothyroidism in that context, then that can cause arthralgias as well. But now she's really sick. And, the history that you gave about the syncope, of course, is very concerning for cardiogenic, meaning although she might have just maybe been a little bit dizzy earlier or just kind of weak with the blood loss or the heavy menses, it sounds like she just was walking and then dropped. And that, of course, is concerning for cardiogenic of some kind, either an arrhythmia or some other cardiac source. And here we have basically a critically ill patient with multi-organ failure. Well, we don't know their labs yet, but I'm assuming she's going to have multi-organ failure in the context of at least of her cardiorespiratory compromise. I mean, and then from there, what I would say is, again, we have to have a system for approaching this. I mean, this can be a patient who has had a chronic lingering process and then she just develops sepsis or some other cause of acute organ failure. From a rheumatologic perspective, it's actually only a short list of things that can cause severe multi-system illness, especially to this degree. So Jeffrey knows this. One of the things I like to talk about with our fellows is basically what are the rheumatologic emergencies or what are the things that can cause someone to become this critically ill? And it's a short list. Lupus is on it. And certainly lupus can do this. Lupus can cause a cardiomyopathy, pericarditis. That alone can certainly lead to respiratory compromise, or you could get kind of a direct pulmonoparenchymal compromise with either ILD or alveolar hemorrhage, often with co-occurrent antiphospholipid antibody syndrome. You would worry about CAPS in this patient, so catastrophic antiphospholipid antibody syndrome, which can cause multisystem disease. You have what appears to be either vasculitic or vasculopathic changes in the skin, and that could certainly be consistent with CAPS. This patient could have both of those things, and she could have macrophage activation syndrome, which can also lead to severe multi-organ failure. MAS, of course, can be secondary to other rheumatic diseases, infections, or cancer, or it can be a primary process related to HLH. But that's something that we'll be looking at and thinking about. Vasculitis causes this kind of severe disease. So ANCA-vasculitis, this would probably be most consistent with a small vessel vasculitis, of which there are many. So the paradigm for vasculitis is it a primary systemic vasculitis, meaning either a posse-immune or immune complex mediated autoimmune primary vasculitic syndrome? So ANCA-vasculitides versus more immune complex related diseases like cryoglobulonemic vasculitis, et cetera. Having those things in your head are important to make sure you have a complete workup. Like as we're working this patient up, essentially, we're going to send MAS labs. We're going to send complements for lupus, but also for cryoglobulonemic vasculitis. We're going to send a rheumatoid factor and an SPEP and free light chains. We're going to send hepatitis studies. Like all of these things is just to help us differentiate between these things. And then, primary systemic rheumatic diseases can also present with vasculitis. So if anybody's seen that like figure of large, medium, or small vessels where you're kind of working through a differential that way, that's what's necessary for primary systemic vasculitides, but it does not include secondary vasculitis like lupus with vasculitis, Behçet's with vasculitis, etc. So these are some of the things that we're going to be working through. Anyway, getting back to the list of things that can kill you in a rheumatic disease situation. Well, again, lupus, sepsis, vasculitis, and macrophage activation syndrome, catastrophic antiphospholipid antibody syndrome, scleroderma renal crisis can do it. So that's kind of a microangiopathic process. And then I always like to remember two other things that can cause critical illness. One is MDA5 dermatomyositis that leads to really severe rapid pulmonary compromise. It does not sound to me like this patient has the typical rash of MDA5, et cetera. But the unique aspect of that is that's more of an ARDS-like picture as opposed to alveolar hemorrhage. And then finally, Castleman's syndrome or Castleman's disease, which is kind of, it blurs the lines between us and hematology. But things like Tafro in particular can lead to really severe critical multisystem disease. So, and that's a lot, but like these are the lists that I think are important in this patient is like what can kill someone from a rheumatologic perspective, what can cause multisystem organ failure, and then working back to like hone that by what exactly does this patient have so you can order your list by what's most likely.
Amazing. Thanks so much. This is a very complex patient, and you've helped break it down for us and teach us about how to think through this. And I love hearing your thoughts and always love hearing your talk on the rheumatologic emergencies. I think it's such a valuable thing to pay attention to. Um, Monosini, you want to share the next outline?
That was a rich discussion. Yes. So the patient was found to be in severe cardiogenic shock in the ER with bedside POCUS echo showing an ejection fraction of less than 15%. And she was sent directly to the cardiac ICU and started on continuous dobutamine infusion and given broad spectrum antibiotics. After 5 days, she had minimal improvement and worsening AKI. So coming to the labs, on CBC, we found a WBC count of 2.4 with lymphopenia and neutropenia with absolute neutrophil count of 1,300. Hemoglobin was 8.7, hematocrit of 24, and MCV of 80. Platelet was 47, and BMP, sodium of 132, potassium of 5.8, chloride of 100, BUN, BUN of 56, creatinine of 3.8, which was high, and albumin of 2, protein of 5.4, glucose 105, and a carbon dioxide of 23. AST was elevated at 82, ALT of 33, and alkaline phosphate 87 within normal limits. Creatinine kinase was 384, which was slightly elevated, and ESR of 30, CRP of 5.6, elevated, ferritin of 140, and LDH of 40. Urine analysis was positive for 3 plus proteinuria, 2 plus blood with many WBCs and RBCs. Urine protein slash creatinine ratio was 4.2 gram. Yeah, that would be my aliquot. Would love your thoughts.
David, I know there's a lot of things said in that aliquot, so if you didn't catch anything, feel free to ask again.
Yeah, so do I get a ferritin?
Yes,
Or
I
am I
believe
not
it
blood?
was normal.
Ferritin was normal. Okay. Yeah, and then the CRP you said was 5.6. Is that milligrams per deciliter as opposed to milligrams per liter?
Yes.
Great.
Yes.
It's
Yes.
Okay. Yeah, got it. And then which way are the AST and ALT? I saw one was 82 and one was 33, but which one was which? Sorry, just so I...
Yes, the AST was 82 and the ALT was 33.
Okay. And the ferritin was normal. All right. Well, that's fine. So, all right. I mean, I think a couple of things. This patient, again, consistent with their critical illness, has, essentially pancytopenia. They've got AKI. It's a little unclear if they have liver failure or not. I didn't catch a bilirubin, but certainly there's concern for liver irritation. The CK elevation suggests that potentially that AST is from the muscle as opposed to liver, but usually the CK needs to be a lot higher for it to be related to that AST as a muscle enzyme as opposed to a liver enzyme. As we think about putting together patterns, well, here we have a pulmonary renal syndrome, essentially, right? So we've got, lung disease with diffuse crackles and proteinuria, hematuria, et cetera, with a high urine protein and creatinine ratio. We have to be a little bit careful when we invoke a pulmonary renal syndrome because this patient's pulmonary disease could certainly simply be a consequence of their cardiomyopathy as opposed to a true direct parenchymal disease of the lungs. But if it were to be a pulmonary renal syndrome, it certainly could be alveolar hemorrhage related to all the things that cause pulmonary renal syndromes: ANCA-vasculitis, lupus, antiphospholipid antibody syndrome, other forms of vasculitis like cryoglobulinic vasculitis, infections, valvular disease, coagulopathies, etc. I think the things that concern me most about this case, from my standpoint, besides just how sick she is the pancytopenia. So obviously, normally when someone is this ill from sepsis, you're going to see leukocytosis, or you're going to see, but this patient has leukopenia. And that raises concern for a couple of things. One is, lupus. So lupus can cause diffuse cytopenias. So in and of itself, when lupus is active, you're going to get leukopenia. It can certainly cause anemia from many other ways, either just a direct antiglobulin or a microangiopathic process. Similarly, the thrombocytopenia, it can be it can be an ITP-like process, a microangiopathic process. It can be overlap with TTP. There's just a lot of ways that you can get thrombocytopenia from lupus. I would worry about macrophage activation syndrome as a complicating factor in this patient because there are several things in her labs that point in the direction of that kind of hyperinflammatory state. The cytopenias, the elevated AST, the elevated CRP with a relatively normal ESR, I believe it was about 30. Um, these things point to something like macrophage activation syndrome. The thing pointing against that would be the relatively normal ferritin. But again, we already knew that this patient had heavy menses. So potentially this kind of has been brewing and she's just lost all her iron. You said her MCV was like 80. So maybe we have a mixed picture where we've got inflammation, iron depletion, and still this hyperinflammatory state. One tool that you can use when you're in this situation is you can pull up something called the H score, and you can put in her labs, and that can give you a likelihood of whether or not this patient is in a hyperinflammatory state that we might categorize as macrophage activation. That still doesn't tell you what the driving force of it is. Is it lupus? Is it vasculitis? Is it an infection? Is it a hematologic malignancy? But it can at least tell you how much inflammation are we dealing with, and do we need to temporize her with some MAS type measures while we're working this out. I mean, I think the other part of this, when we think about all this, is we can anchor on rheumatic conditions. We can think about an infection. I mean, she's on broad spectrum antibiotics. We're going to go through serologic workup. But there are some hematologic mimickers of lupus and other rheumatic diseases. So something called angioimmunoblastic T-cell lymphoma can pop off serologies and other things that look just like lupus and cause a lot of the same things. I recognize that this patient has diffuse lymphadenopathy, which certainly can happen with lupus-like syndromes, et cetera. But I mean, if I were in charge of this patient, I mean, I would send, in addition to cultures, et cetera, you would obviously want pulmonary imaging. If she's stable enough for a bronchoscopy to look for evidence of alveolar hemorrhage, you would want that. And then I would ask for broad serologies for lupus, ANCA-vasculitis, Goodpasture's syndrome. Um, you want the full SPEP, UPEP, immunoglobulin or free light chains, complements. You want your rheumatoid factor, CCP. You want your hepatitis B, C. You want your HIV. You want your quant gold. You want all that stuff. And hopefully with that, you'll at least have some ways of helping her get better while you're figuring out what's wrong. A kidney biopsy would be helpful. Her platelets are too low for that. She's not stable enough really at this point for that, but once she's temporized, that would be really helpful.
I love it. It's so amazing just getting to see like just off the top of your head how you just smoothly are able to just go from this complex patient story, then list like 10 recommendations just without even having to really pause and think necessarily about it, about what you would do next. I have a couple questions just so we can squeeze even more learning from you. One of the questions is, I can imagine that sometimes when these patients first get presented, because they're presenting with this cardiogenic shock, so initially, it could be that you have no story. Patient is too sick to really give you a story, and they're just in cardiogenic shock with an EF of less than 15%. And I guess my question is, are there rheumatologic diseases that you think of that can present with cardiogenic shock, or do you think that may be something unrelated?
Yeah, it's a good question. I mean, I think there are a variety of conditions that can lead to cardiomyopathies in rheumatology. One of them is your favorite, Jeffrey, sarcoidosis. So cardiac sarcoid is a big one. And that one's really tricky, right? Because it can be pretty silent, and then they can show up and their EF is low, or they just present with arrhythmias. I mean, I would worry the reason this patient dropped is that she had a ventricular arrhythmia. I mean, it sounds like she was fine, and then boom, down she went. Um, but lupus can certainly lead to a cardiomyopathy. Honestly, most rheumatic diseases, if you really, you want to do some case reports, you can certainly find that. You didn't mention her eosinophil count on the diff, but one that comes to mind that is unique other than just like we've got sarcoid, we've got lupus-like syndromes leading to a lupus cardiomyopathy, but the spectrum of EGPA up to hypereosinophilic syndromes can certainly lead to a cardiomyopathy that is kind of unique. It's you see kind of trabeculations and thromboses in the ventricle. It's just a little bit of a different flavor of cardiomyopathy than just the straight, we've got autoimmune disease with a cardiomyopathy. I mean, I think there's a lot of other things to think about, though, in the heart. Like, why is this heart not working? Well, is it because this patient has something truly infiltrative or inflammatory of the muscle itself? I mean, in that context, like inflammatory myopathies can actually affect the heart, you know? I mean, that's usually we think of it as proximal muscle weakness, but it can affect the heart. Um, Lupus can do it, et cetera. But we also need to recognize that our patients with autoimmune rheumatic disease are at a very high risk of cardiovascular problems. And she could have just had a coronary event, um, or vasculitis of the vessels, or vasospasm of the vessels. Our conditions are also associated with valvular disease. So you think about like Lehman-Sachs endocarditis or Morantic endocarditis, or even just APS associated with valvular heart disease. So there's a lot of ways that it can happen. Fortunately, we have really smart cardiologists that can put a probe on and tell us what's going on, and usually tell us if there's wall motion abnormalities or what's going on with the valve. Sometimes we need a cardiac MRI or cardiac PET to give us further information. I've seen a patient, for example, with cardiac sarcoid where they had the subendocardial inflammation, indicating they'd had a coronary event in addition to kind of transmural inflammation. So like it can be really challenging, but hopefully an echo and can at least give us some hints as what's going on with the heart.
And then one final question before we go to the next aliquot. Yeah, I know you mentioned initially there's a lot of different ways that you can get the cytopenias in lupus. And I'm curious, with this patient's anemia and other cytopenias, what would your kind of workup be from a rheumatologic perspective to investigate that further?
Yeah, I mean, this patient with pancytopenia, especially anemia and thrombocytopenia with an elevated LDH, like the alarm bells are ringing for a microangiopathic process. So in addition to serologies for all the rheumatic things that can do that, like, APS, lupus, ANCA, and then getting your, TTP workup, you'd also want to haptoglobin and other things like that. But yeah, I mean, that would be my first thing. I mean, you can get a DAT as well. If there's lupus, you might see some of those hunting around. One of the problems is it's a little bit difficult to make heads or tails of what's actually driving the issue, because sometimes you'll see DATs positive, but that's not actually the issue. So yeah, I mean, I think that's what I would say. I mean, we also, of course, want, you didn't mention any sclerodermatoid kind of features. You said diffuse hand swelling, but early scleroderma can present with puffy hands. So that plus the Raynaud's concern, there's like some things in my head there. You could send an RNA polymerase 3, but I think some of the, that's one thing that you could think about. Patients with scleroderma renal crisis do commonly have pericardial disease as well. So like a pericarditis or tendon friction rubs. Basically, I think of like RNA polymerase 3, scleroderma renal crisis rubs. Like these are some of the alarm bells that you could ring. But I mean, that's one where you just want to carefully examine the skin, if you can look at the nail folds, et cetera, et cetera. Yeah.
Awesome. Thank you so much. Sweeney, why don't we go to the next aliquot?
So here's the next aliquot with hematological exam showing positive schistocytes on the smear with undetectable haptoglobin, and indirect bilirubin was also undetectable. SPEP, UPEP, and IFE showed polyclonal hypergamma globulinemia. Uh, ADAM STS 13 was slightly low. not concerning for TTP. And Coombs test was negative. ID panel was negative for blood cultures, viral respiratory panel negative, COVID, HIV, TB, hepatitis, syphilis, and monospot, histoplasma all turned out to be negative. TTE showed no vegetations, but ejection fraction was severely reduced and no valvulopathy. Coming to rheumatological exam, ANA was positive at 1 is to 2,560, and ENA panel showed double-stranded DNA titers were high, SSA titers were high, and RMP also had high titers. And C3 and C4 was reduced. P-ANCA was positive as at 1 is to 40, and cryoglobulins were negative. RF had showed high titer, but CCP was negative. Lupus anticoagulant negative as well, with anticardiolipin IgM and IgA were elevated, with anti-beta-2 glycoprotein negative. Coming to the imaging, we got chest CT angiography was done where there was no pulmonary embolism, and bilateral basilar predominant consolidations and GGOs were seen. There were small bilateral pleural effusions and pericardial effusions. Scattered prominent mediastinal and axillary lymph nodes were seen. On CT, abdomen and pelvis, there was mild mesenteric and inguinal lymph nodes with reactive appearance, no hepatosplenomegaly, no masses, and the MRI of the brain was normal. That's the end of the fifth alloc.
Yeah, I know we're coming up on time, so I'll be brief. I mean, this essentially is a good case for this patient probably has a raging systemic rheumatic disease with features essentially of mixed connective tissue disease with lupus as the predominant problem. I mean, you've got evidence of, I mean, if you want to put her in the classification criteria, she's certainly got inflammatory arthritis, hematologic processes, serositis, all the serologies that you need to make that diagnosis. The RNP brings my attention in that patients with more of an MCTD type picture typically have more interstitial lung disease than straight patients with lupus. But in all reality, in a case like this, it doesn't really matter. You're going to be treating her aggressively. The P-ANCA catches my attention. I'd want to know if there's an MPO or a PR3, but again, you can have overlap of ANCA vasculitis with patients with lupus. Certainly sounds like she has antiphospholipid antibodies as well. So I'd be highly concerned that this patient has catastrophic antiphospholipid antibody syndrome with the thrombotic sounding areas of her legs. And so, you could potentially even get some additional information with a biopsy of the skin to look for kind of diffuse thrombosis. Differentiating that from like just DIC or vasculitis can be really challenging, but that's one that you'd really want to catch because while you in a case like this, I mean, you can quibble a little bit. Should we get a lymph node biopsy and look for angioimmunoblastic T cell lymphoma as a mimicker, et cetera? Sure. But in this acute context where a patient is this sick, what you're going to do is you're going to treat her really aggressively. You're going to probably do pulse dose steroids. If you are concerned enough for catastrophic antiphospholipid antibody syndrome, you'll likely do plasma exchange to try to help clear those antibodies and help her with her multi-organ failure. We typically don't do that for lupus alone, but in the context of CAPS, we'd be really worried about that. So if you feel like you have high enough suspicion, again, I haven't seen the skin, but that's something you'd worry about. And then really, like once you have more certainty, then you'll start thinking more about aggressive therapies like Cytoxan or other things. Yeah, she's sick. We need to treat her aggressively with kind of salvage therapies. And then we'll sort out the rest later with a kidney biopsy once we have things better, et cetera.
Okay, well, Sweeney, why don't you give us our last alcohol? Thanks so much, David, for going through all that and letting us learn from your experience and knowledge.
Yes. So here goes the last aliquot, where the kidney biopsy was done, and it showed acute tubular necrosis and microvascular thrombosis in multiple glomeruli and arterioles consistent with thrombotic microangiopathy, immune complex mediated membranoproliferative glomerulonephritis with immunofluorescence showing a full house pattern suggestive of class 4 um, nephritis. And lymph node biopsy showed reactive hyperplasia consistent with inflammation from an autoimmune disease. With would like your thoughts before I proceed with the diagnosis.
Yeah, I mean, that fits with the clinical impression. So anchoring at the beginning helped me, but it's again important to think broadly. I mean, this patient has lupus/MCTD. Again, I'm still worried about that microangiopathic process with the thromboses seen in the kidney biopsy. Take this together with, I think you said it was the anticardiolipin antibodies that were positive and the thrombotic appearing lesions of the legs. The microangiopathic process raises concern for catastrophic antiphospholipid antibody syndrome in the context of this patient's severe acute presentation. So I'm also worried about that. But other than anticoagulation and potential plasma exchange, the treatment is largely the same. You could think about eculizumab or other kind of advanced therapies for microangiopathic processes and CAPS that are more complement mediated in patients like this. In addition to those therapies, it's not 100% clear if that's the right thing to do, but we do it in cases where patients with lupus with microangiopathy borderline into things like atypical HUS, and especially in patients with antiphospholipid antibody syndrome. So that's what I'm worried about.
All right, why don't you share our final diagnosis and what ended up happening with the patient?
So the diagnosis as currently diagnosed is systemic lupus erythematosus (SLE), and the patient had multiple manifestations of lupus, and the patient was given eculizumab, high-dose steroids, and cyclophosphamide with plasma exchange. And it's truly an honor to be presenting to you, Dr. Leverins, and it's very humbling to be presenting. And this is Dr. Jeffrey's case, so we'd love to hear what Dr. Jeffrey thinks and the teaching points as well that he learned.
Yeah, incredible session. Thanks so much both for presenting this case and then David for allowing us to learn from you and this incredibly complex patient. I think when I saw this patient, so this is a patient I saw when I was a resident at UAB.
Oh,
And
that's why I don't know it.
yes,
Like, which
exactly.
one is this?
David, it was astounding because the patient came in to the CCU directly for cardiogenic shock, and nobody had gotten a history for like 5 days. But because the AKI wasn't getting better on dobutamine, they're like, "Oh, something else must be wrong besides just the heart." And then we realized there's like a ton of other things going on. And I think at that time there was it was some confusion because I haven't heard before that lupus could cause a TMA-like process, or was this a TMA, or was this like CAPS, or was this something different? We actually had consulted hematology, and they said that they didn't think that this was a TMA, and so because it didn't wasn't consistent with everything else that was going on. And then one learning point that I had was that you can have a TMA-like process with lupus. Whether that, I think it's not fully well understood, but it's thought to be complement mediated and goes in between this kind of TMA, like atypical HUS scenario, or a maybe catastrophic APS scenario. So we ended up kind of, as we often do, treating this patient for everything possible. And they eventually did better. So really enjoyed being able to share this case with you. Any final thoughts, David, on reflections before we hand it over to Hans for teaching points?
Yeah, that's great. No, I mean, thanks for the opportunity. I mean, I think as with all things rheumatology, it's all in the history. And there's certainly some pattern recognition, but talking to our patients and their families is where it all starts. Kudos to you and to your team for going back and finding those historical clues that really led you to finding this. Because I mean, you really can't blame those teams, because this, if without that history, this just looks like sepsis or cardiogenic shock, or, one of the many patients in the ICU with severe multi-system disease, and we don't exactly know why. So yeah, nice job. And Madhuswami, very well presented. Thank you.
Thanks so much again. Hans, why don't we go to teaching points?
Yes, today's patient was not only very sick, but extremely complicated, and I hope I'll get a good summary of it. The patient presented with multiple symptoms, among them loss of consciousness, heavy menses, petechiae-like bleeding. Diathesis was one of the thoughts that came up, because she showed a vasculitic-like rash on her extremities. She had orthopnea, that is something like cardiogenic involvement. And of all those dots, and those include chest pain as well, we look at the most serious ones at first before we try to find any path towards a diagnosis. Also, we've learned to distinguish between signal and noise. As we proceeded, patient was shown to have morning stiffness, symmetrical arthralgia, with loss of involving her fingertips in the cold, as well as in altogether, it looked like a massive inflammatory process. And of those, the differential at that point is extremely wide. We have rheumatoid arthritis as one possibility, SLE, or mixed connective tissue disease. The outstanding symptom that were shown was a severe multi-system involvement, and SLE seems to fit very well in conjunction with CAPS, the catastrophic antiphospholipid syndrome, but also macrophage activation syndromes would fit in there as well. Amongst them, HLH being one example, including all the kinds of vasculitides, which is again connected to SLE in one way, because we have CAPS, and then there is bleeding into the tissue surrounding. MDA5 protein dermatomyositis would be another thought, as well as hematological problems, lymphoproliferative problem like Castleman, and Tafro came up. We had furthermore an involvement of the lungs and the kidneys, with possibility of bleeding into the alveoli. Again, ANCA-associated vasculitides, GPA is one example, would fit as well. So does SLE once again, as well as infections and all kinds of coagulopathies. The next finding was pancytopenia, and there we have our schemata of, I think, the 3 S's, where substance is missing, like certain vitamins and minerals for the bone marrow to produce enough blood cells, as well as infiltration from outside, including cancers and infections like Leishmania can infiltrate the bone marrow and cause pancytopenia, so does TB, as well as certain malignancies. And this again might bring us up to HLH as a possibility. Other possibilities are chronic and severe inflammations, and SLE would fit again. And the pancytopenia fits very well with her heavy menses and her petechial rash. The serology was then very much indicative of a broad, strong inflammatory disease. We were able to explain her problem with orthopnea at night, and she mentioned she has to sleep on 3 pillows, with the possibility of coming up with the diagnosis of SLE involving multi-systems, including the heart, which can cause an endocarditis or a pericarditis known as Lippmann-Sachs syndrome. The final diagnosis was SLE with multiple manifestations. Patient was treated, I think, with a high dose pulse including plasma exchange in the context of CAPS. It was a really complicated case, and I hope that everything was kind of summarized okay. That was one of the most difficult ones that we
Yeah,
had this week. Thank you very much.
yeah, thanks so much, Hans. This was such a complex patient. You did such an amazing job trying to keep down the teaching points to focus us on the things that we got to learn today from Dr. Leverins when going through the case. So thank you so much, and thanks so much again, David, for coming here and sharing us your teaching points and thoughts.
Yeah, fantastic teaching points. Thanks for what you all do. This is a wonderful format, and thanks for having me. It was really fun.
Awesome. See y'all next time. Bye.